Grand Rounds. My name's Dave McClellan. I'm the program manager for the Merge Collaborative. This program is sponsored between the Merge Collaborative and the Building Maine Network, which are both grants that are made possible by the Maine State Department of Health and Human Services. Today, we are thrilled to welcome Annie Durthick. Annie is a clinical psychologist and the director of behavioral science at the Central Maine Medical Center Family Medicine Residency, where she also serves as the associate program director. In this capacity, Dr. Durthick, she oversees the process of resident evaluation and is also involved in faculty development, resident remediation, curriculum development, and program evaluation. She serves as the chair to the Merge Executive Council, which oversees the fiduciary and strategic vision for the Merge Collaborative. And we're thrilled to have her as a guest speaker today for her presentation, Evidence-Based Strategies to Improve Learning and How to Implement Them in Medical Education. So I'll invite everyone to leave your cameras off during Annie's presentation. And when she's all done, we'll go into a Q&A. We'll turn those cameras back on and have a great discussion. So Annie, the floor is yours.
Thank you, Dave. I think we can provide this information again at the end, but hopefully everyone's had a chance to text your information to get CME. There are a couple of requisite announcements as well to make sure that you know I have no disclosures to make, no financial incentives for providing this training today. I am going to focus on the science of learning just a little bit more broadly, but will be emphasizing evidence-based strategies for clinical teaching today. In order to help that be most helpful for you, I'm going to provide some context, focusing on a brief overview of the science of learning and provide some refresher or intro, depending on kind of where you're coming in at this, on the mechanisms of learning and memory so that you have something to kind of hang this information on as we go over it, and introduce a couple of concepts, specifically the cognitive load theory. So the science of learning, we talk about what is the science of learning. It is a really broad field. It is an interdisciplinary field drawing from multiple theoretical perspectives, research paradigms, and methodologies to investigate teaching and learning, as well as the design and development of learning environments, with the ultimate goal to improve the effectiveness of education and training. Cognitive psychologists have been studying the science of learning for well over 100 years. It's really been in the last decade, couple of decades, that this base of knowledge has been applied in a more focused way to improve medical education. But even just within that short period of time, the literature has really proliferated. There is a ton of research to support the science of learning and what we know about how to apply these concepts to improve medical education. The field of psychology, though, has really been at the core of the research on the science of learning since its inception. In the late 2010s, though, there was a shift towards a more specialization in the subfield of cognitive psychology specifically, and then later a more explicit focus on the biological and kind of neural explanations of learning. Recently, there has been an emphasis on computer-based approaches to understanding learning, given a lot of the advancements in neurotechnology that can facilitate the collection of brain-based data outside of really highly controlled lab spaces. Interestingly, though, the evolution of the science of learning has followed a different trajectory when compared to broader definitions of learning itself. So while definitions of learning have generally shifted from biological to cognitive to most recently contextual or sociocultural theoretical lenses, definitions of science of learning have almost exclusively emphasized biological and cognitive aspects of learning, very rarely acknowledging the influence of contextual factors. In one recent case, a researcher actually emphasize the irrelevance of the learning environment on the science of learning, stating much of this work draws on the tradition of psychological methodologies of experimentation in laboratory settings or individualized designs in which students are pulled out of their everyday classroom context to participate in a study. So as you'll see, the rest of my presentation really does focus on biological and cognitive explanations of learning. So how do we actually learn? That's important to understand in order to optimize learning strategy interventions. So this is a complicated question. I'm going to try to break it down into the most parsimonious explanation possible. Information is raised to the conscious awareness through sensory memory. We have aliquots of information. This is a shout out to my Canadian friend, Dr. Baraklis. Aliquots of information are raised to the conscious awareness through sensory memory and then enter the domain of working memory. Working memory reorganizes that information so that it can be effectively stored in packages of information in the long-term memory. Long-term memory has theoretically limitless capacity in terms of the duration and volume of what it can store, but a route map is required to retrieve that information at a later date. The working memory, it encodes the information with this route map to enable the retrieval of that information later when we need it. Unlike sensory memory and sensory memory and long-term memory, working memory is not infinite. In a famous 1956 article, it was postulated that the working memory cannot process more than about 7 independent units at a time, and subsequent research has confirmed this. In medical education, the majority of sensory information comes in the form of sounds and images, although touch and smell are also important, but I'm going to focus on visual and auditory memory. The visual and auditory systems perceive a vast amount of incoming information, but they can only hold any given piece of information for only a very brief period of time, less than about 0.25 to 2 seconds at a time. Most of the perceived information never even reaches our conscious awareness. But when a learner does attend to information in sensory memory, such as like the words of an attending clinician describing the pathophysiology of congestive heart failure, the information moves to working memory. So the learner must have an intact capacity for attention in order to screen out irrelevant stimuli, such as like a bird chirping outside of the window or a peer rustling through their lunch bag during a lecture, and then screen in relevant sensory information, such as a patient's history that they're providing or a rash they're observing, in order for the working memory system to process that information. As I mentioned earlier, a learner's working memory can hold no more than 7 plus or minus a couple information elements at a time, and it can only actively process, meaning organize, compare and contrast, no more than 2 to 4 elements at any given moment. In addition, working memory can only hold an information element for a few seconds, with almost all information lost after about 30 seconds, unless it is actively refreshed by rehearsal. For example, repeating to yourself an important lab value or telephone number that you just verbally received until you can write it down. The limited capacity of working memory has a profound impact on the rate of learning. Many learning tasks, especially complex clinical activities, entail way more than 7 units of information. For the learner to work within these constraints, all of the information elements must be combined and reorganized into just a few meaningful units. Information processing and working memory refers to mentally rearranging words and images into a coherent cognitive representation. We call these schemas, and we connect these with relevant prior knowledge that is activated from long-term memory. So for example, when we see a bowl of like steaming hot yellow liquid that's filled with bits of colorful vegetables and white bits of meat, we connect that to a schema called chicken noodle soup, right? The limitations of working memory capacity and duration are particularly evident when the information is novel to the learner. The absence of a pre-existing schema like chicken noodle soup and long-term memory that allows us to organize this new information means that the learner's working memory can very easily become overwhelmed. So for example, in assessing a patient with like major depressive disorder, the new learner's working memory will be fully taxed simply by processing the different possible permutations or interactions of the patient's key symptoms, like no interest in activities, fatigue, lethargy, weight gain, a sense of heaviness in the extremities. A more experienced learner will immediately reorganize all of these separate data points into a pattern and be able to chunk that information into one element, atypical major depressive disorder, into their working memory rather than a host of individual symptoms. So illness scripts, for example, are schemas. The illness script for a major depressive episode organizes all these various symptoms and signs into one construct. This reduces the number of individual information elements into kind of an infinite number of permutations into one schema or chunk that helps the learner differentiate a major depressive episode from dysthymia or flu or something else. So unlike working memory, long-term memory is theoretically limitless in its capacity to store information. It holds schemata that vary in their degree of complexity and automation. So I want to connect these ideas to expertise. So expertise does not come from a superior ability to analyze multiple pieces of novel information. Expertise does not come from a general ability to problem solve better than others, and it certainly does not come from better working memory. Expertise is an adaptation. It stems from the ability to efficiently organize and reorganize information by comparing what is perceived against an extensive domain knowledge that is stored in very well organized schemata in long-term memory. Expertise is critically dependent on long-term memory. This has been well demonstrated with masters of their craft in chess, baseball, electronics, mathematics. Masters of their craft are consistently able to reproduce novel configurations when they require them to rely solely on pre-existing knowledge. But when they are required to rely on problem solving skills or critical thinking, there's zero difference between masters and amateurs. So taking all of that into consideration, learning can be defined. I am using a definition here. There are other conceptualizations, but learning can be defined as schemata construction and automation. And by that, I mean that in the process of learning, learners construct schemata, they construct these scripts during knowledge acquisition and problem solving by combining and recombining elements together into larger and more refined chunks. And several cognitive processes facilitate this, including activating prior knowledge, comparing new information with what we already know, elaborating knowledge, incorporating new elements into schemata stored in long-term memory, and then obtaining already schematized information from other people like supervisors and peers. And then with extensive practice, a schema can become fully automated and act as a central processor, organizing information and knowledge without conscious effort, and therefore without overburdening that very limited working memory. With automation, familiar tasks are performed accurately and fluidly, whereas unfamiliar tasks that require non-automated processes cannot be learned efficiently because your full working memory is not available. So now I want to talk just very briefly about the cognitive load theory, which contends that we can best facilitate learning, schematic instruction, and automation by regulating our cognitive load. Cognitive load theory was developed by John Sweller, who was an educational psychologist in the 1980s, I believe. It starts with the premise that learners have limited working memory and that this has very important implications for instructional design because learning requires the processing of information in working memory. At its most simple, learning suffers when the cognitive load exceeds the working memory capacity of the learner. Therefore, a cognitive load theory prioritizes optimizing information processing and working memory. So cognitive load theory identifies three types of cognitive load. First, there is intrinsic load, which is the load associated with the task. Two, extraneous load, which is the load that is not essential to the task. And three, germane load, which is load imposed by the learner's deliberate use of cognitive strategies to reorganize information to make it suitable for storage in long-term memory. So basically, the load required to learn. Cognitive load theory contends that we can best facilitate learning, i.e., we can best facilitate schematic construction and automation by regulating cognitive load via three strategies. So first, managing intrinsic load by simplifying tasks. Two, decreasing extraneous load by decreasing like interruptions, for example. And three, optimizing germane load, meaning encouraging the use of cognitive strategies that facilitate this schematic construction. And here are some ways that we can do that. I'm not going to spend time reading this to you, but I'm going to show you some other strategies here in just a moment. These slides will also be available if you want to read each one of these bullet points, but I think just having the general concept of these ideas of decreasing intrinsic load, extraneous load, and optimizing germane load are helpful. So I'm going to present 6 evidence-based strategies to improve learning. These were initially developed in the context of general education, but they have been replicated in medical education multiple times. And as I present these, I think that most of you will identify that you're already doing these things. And I think that it is actually helpful to just label what you're already doing so that you can be more intentional about continuing to do it in the future and planning for it. If this intrigues you at all, if you want to know more about it, I would encourage you to listen to the Curbsiders Teach podcast episode on the science of learning and strategies. I would encourage you to listen to this podcast. Anyways, if you're interested in medical education, it's excellent. But this episode in particular is very good. So the first strategy I want to introduce is spaced practice, which refers to learning and revisiting material over time, as opposed to mass learning or like cramming, which we all know doesn't work. It is one of the most efficient learning strategies, and it is largely attributed to the limited capacity of working memory. Other psychological functions responsible for the beneficial effects of spaced practice um, include procedural learning, priming effects, expanding retrieval. I'm not going to get into all of those today, but there is a lot that is happening that makes this effective. So ways to be really intentional about doing spaced practice. You can break it up, reconceptualize your lectures. Why do they always have to be an hour or 45 minutes? We know that learners can't process that much information, especially if it's novel information, in an hour chunk of time. So why can't our didactics be like 15 minutes? Each didactic lecture be 15 minutes and present information in a way people can process it. Plan for spaced practice within your block of teaching units. We know that performance of students who hear content one time in one lecture will be lower than those who hear it frequently over time. Make it a game. Use your institution's social media to revisit content over and over again. Rethink your PowerPoints. Design learning materials to be less focused around a specific lecture topic and reintroduce other content. Help learners create a study schedule and remind them that it will take initial investment. Optimize the use of apps and technology. Anki helps create flashcards, help your learners create reminders. It does take time and investment to build this infrastructure, but it will be helpful in the long run. The next strategy is elaboration. This involves expanding details around a concept by asking how and why questions to help build comprehension beyond just a base knowledge of facts. This technique is not as valuable with novices who need to have information to answer questions, but can help advanced learners create connections and solidify understanding. Elaborative interrogation is a specific method of elaboration. This involves asking learners specific questions about how and why things work, such as how does X work? Why does X happen? When did X happen? What caused X? What is the result of X? This challenges them to produce explanations for the ideas they are learning in relation to things they already know or have already experienced. So creating those schemas. This also helps them organize new ideas, making it easier to bring to mind later on. Other strategies for elaboration, mnemonics, we're all familiar with mnemonics, but they don't have to be just cute acronyms. You can create rhymes, you can use photos, you can even do gestures. Rewriting is a great way to do elaboration. I really like using your objectives from a lecture. So at the end of a lecture, revisit your objectives and ask your learners to write down what they learned about each one of those objectives. It helps them put in their own words what they learned. Comparisons are another great way of teaching elaboration. So showing a picture of like normal tissue, then compare it to abnormal tissue. You can also create concept maps. So here's a very like just simple version of a concept map, but it helps kind of elaborate how all of these ideas are connected to one another. I also really like this intervention called the 1-minute essay. So at the end of a lecture, have your learners write a 1-minute essay. So for example, how does this lecture relate to January's lecture on AI? Just take 1 minute to write this essay. What parts of this lecture do you not understand? So the next strategy is concrete examples. So this helps solidify an abstract concept. Um, should find multiple examples that are different from each other but specific to the concept to further understanding. Using just one example can make the learner think that that example is the thing that you're talking about. Instead, use multiple varied examples to allow learners to not associate the concept with just one specific aspect, but are able to see multiple similarities or connections between examples and then stimulate complex thinking patterns. Um, so some ways to do this. Well, first, don't rely on novices to fill the gaps in complex thinking. Give them a roadmap for real life application. Pause teaching to talk about a case, for example, or to pull up online resources that can extend learning. When you're preparing your teaching, whether it's clinical teaching or whether it's a lecture, ask yourself, what do I want them to be able to do in 3 hours, 3 days, 3 years? And then provide specific examples of those things. Bring learning to life by using images, test results, labs, etc. Pull them up, look at them together. Dual coding is the most effective way to teach. So take home learning point. Dual coding is the most effective way to teach. It refers to the idea that we create separate memory traces for pictures and words. So we combine visual and verbal information to improve retention. Be selective of what information you include to make it add value. We naturally try to make sense of words and we naturally try to make sense of images and read words. So if there are unrelated pictures that we're looking at on a PowerPoint, for example, or there's too many words, it can really hinder one's ability to learn. It increases that extraneous cognitive load. So how do you do this effectively? Well, remember that less is more. If you do have to use words on a PowerPoint, for example, use the fewest number of words possible. Remember, you are the presentation, not your slides. If your slide can be read and understood with no voiceover, then your slide has become the presentation, not you. Concept maps are also a form of they're a form of elaboration, but they're also a form of dual coding. So they're great. When you're teaching clinically, if you're explaining a complex concept, like whip out a piece of paper and say, this is a really complicated topic, like let's chart it out together and look at it. You know, it doesn't have to be a work of art that's worthy of hanging in a museum, right? None of these are examples of great art, but they are really effective for solidifying, consolidating a concept. And again, concept maps are great ways of helping consolidate information. This is something that you wouldn't draw in the context of clinical teaching, but if a learner is struggling, it's a task you might have them do on their own time, like draw a concept map of how all of these body systems are related to one another. There's two more. Interleaving is jumbling or alternating similar concepts to help compare and contrast. So showing a picture of rosacea and then showing a picture of, I don't know, measles or something, and then a picture of rosacea, then a picture of measles, instead of showing 5 of this one and then 5 of that one, alternating between the two so that learners can analyze and delineate them one from another. Um, you know, providing mixed but related different, providing mixed related but different areas of study forces the brain to reconcile the relationship between areas while understanding each very well. So how can you do this in practice? Design learning activities so that you're bringing in previous knowledge, especially revisiting that complex or difficult to master knowledge, bringing that in different shapes and form, and interleaving it with new and novel information. Can also use compare and contrast tables. That's a nice way to do interleaving as well. And then the last one is retrieval practice. And quite frankly, this is quizzing, but it has been proven to be an exceptional method for learning, resulting in durable retention. It requires us to examine long-term memory with priority information, again, in working memory. And it improves memory for the information itself, but also provides us feedback about what needs continued effort. So some examples of how to do this: you can incorporate questions into your clinical and classroom teaching. Creating flashcards is always a great way to do this. I love a good ITE review. So the in-training exam, have the learners sit down and review their in-training exam. So here's just a summary of those 6 methods again. And just as a reminder, you are already doing this. You are doing all of these things, but again, labeling them can help you be more intentional about this. So when you are seeing varied patients on the floor, you're doing spacing and interleaving. But if you can be more intentional about that by choosing the varied patients and kind of interleaving presentations, you might be able to consolidate learning points a little bit more efficiently and effectively. When you're doing case discussions, you're already doing retrieval and elaboration. But if you can approach that a little more intentionally about what questions you want to ask, you might be able to improve learning. So that's all I have. You don't have to do this, but if you want to practice a strategy, you could do a 1-minute essay on your own. So what was the most relevant portion of this talk to your everyday life and teaching, just as a way to practice one of these strategies? But that's all I have, and I'm happy to take questions.
Excellent. Thank you, Annie. I just want to invite you to turn your cameras back on. Wonderful. I'll be curious to hear from the group if what people feel like they're already doing, or any examples of where they've already done one of those 6 things. But certainly, let's give Annie your questions.
Annie, I'm going to just say that that is such a perfect example of a high quality, evidence-based lecture and didactic sharing. So thank you so much for that. I think that's really best practice.
And you implemented some of your techniques. You had minimal words on the screen. Clear models.
Yeah.
Annie, I'm going to date myself, but 20 years ago, when I was studying this, Gardner was all the rage and his multiple intelligences. Is that still in the literature? And is that reflected in any of this? Or has that been sort of left behind?
Yeah, I think it's kind of been left behind a little bit at this point. It still circulates a little bit out there. I think it's been replaced with the idea that there are different learning styles for sure, but we don't focus as much on like multiple intelligences per se. We've kind of moved away from the idea of trying to even really focus on like defining intelligence. It's such it's such an abstract concept, really. But yeah, it's kind of been left behind for the most part. Yeah. Were these ideas, I'm curious, were these ideas brand new to people, or were you feeling like I do all of these things, but like just the labeling of it was new? Like, how did all of that resonate with people? I'm curious.
Hi there. My name's Karen. I'm a surgeon at Mercy Hospital, Portland.
I'm having a hard time hearing you. I'm sorry, Dr. Cole.
Can you hear me?
That's
I
better.
hear you okay. Yeah.
Okay.
Mm.
Oh,
There
anyway,
you go.
I'm a surgeon at Mercy. I have a lot of students come through, MD, DO, PA students. And I will say this wasn't new to me because I did listen to that Curbsiders episode 3 or 4 months ago. So I want to thank you for retrieval practice and spaced learning for me on that. That is a good episode. And I think I heard about that podcast from one of these talks probably right before then. But I was just going to comment that I do think I use these strategies with my students a fair amount, but one thing I hadn't thought about before related to cognitive load was that I do tend to try to teach in the OR, and sometimes I'm doing a case that I've done 1,000 times and it's no big deal to me, and I just go off on a like impromptu lecture about something. And I have a feeling I'm totally overwhelming the students with the quantity of information and the fact that they're all freaked out because we're in the middle of a case and they're trying to pay attention and not touch the wrong thing and not pass out and hit the floor. And so that's what I took away was, maybe I need to tone that down or like give a little disclaimer like, hey, if I'm talking too much and you're losing the thread, just tell me it's okay, but I think I have a tendency to do that because it's my comfort zone and it's fun for me, but I'm kind of thinking back to some of the reactions I get once in a while. So that's what I took away.
Yeah, I think that's great. We have so much that we want people to learn, right? And oftentimes we feel really pressured because we might have people only for a very short rotation, and we feel like we have to squeeze so much in, right? Which is really antithetical to what we know about how to optimize learning, that we are trying to like cram so much in when we know that learning takes place over time. It takes time to revisit this material, to build these schemas. Um, so how can we take some of these strategies and implement them within the confines of and the parameters of the time that we have with our learners, right? It's never going to be a perfect, fit. We're always going to be we're always going to be butting up against the limitations of the systems that we're in, and the what we know about best practices around teaching and learning are never going to fit neatly into the confines of the systems that we have to teach, right? But I think just remembering, like, the learner in front of me can only process about 7 units of information that I'm providing. So how can I help facilitate maybe chunking it a little bit better for them? Perhaps that might be one way to do that. But absolutely, it's a reality. We just have so much that we want to try to share, and our own enthusiasm can like get the train going pretty fast from the station sometimes, for sure. Thank you for sharing that.
Yeah, thank you. I enjoyed the talk.
Thank you. Thank you for coming. Mhm. Any other thoughts or questions? Yes.
He's got a hand up.
Dr. Teacher, I want to say thank you for the presentation. And I had a question about your very good point about not allowing your slides to become your presentation, but remaining the presentation. And I'm a little challenged. I'm finding as a clinical educator with interprofessional health students in both clinical but also community settings, when we do didactic training or even on-site training, we are often asked to have a release a recording of the training available for those who can't attend or for review. And so in it, being able to do that, it kind of defeats the purpose in forcing you to include everything in the slides and allow the presentation to stand alone. So I wondered if you had any recommendations about that.
Yes, that is challenging. I actually wrestled with that a little bit in preparing this presentation. So when the section where I had all of the 6 strategies, I reworked that multiple times because I initially had like this chart with like multiple examples, and then I got to the point where I was like, you should use as few words as possible. It's like, I can't say that when there's like a million words on this screen. So I had to like go back and rework it. But I was thinking that we put these presentations online and I wanted people to have the information. So I was wrestling with that when I was putting this together. So I have a couple of thoughts about it. One strategy might be to include information like in the notes section where people can reference like more detail if they want, but then have diagrams and pictures like in the PowerPoint itself that can help illustrate concepts so that you're not trying to squish everything together where it's just like narrative, but you're kind of teasing that out a little bit, and people can reference a visual description as they are reading the narrative, and it's not as cluttered. So that would be one recommendation. If it is recorded, then I would say you can approach it similarly to if you're giving a live presentation. It is always going to be a little different. And I would say you probably should include a little extra information if it's recorded, anticipating that you're not going to be able to elaborate with questions and things. But if it is recorded, I would say stick to that same principle to include as little information as possible, because it can still be so distracting when there is a lot of text, because now they are trying to they're looking at the PowerPoint on the screen, they're reading the words that are on the screen, they're looking at the picture, and they're listening to the recording in addition to all of the other distractions of online learning. So I would say it's especially important then to limit the distraction. And then also if you're disseminating information via like virtual learning, there's a lot of evidence to suggest like animated dissemination is really helpful. This requires a lot of like resources, and I don't know what kind of resources are available to anyone. It also has a lot of time, but like video shorts are really helpful. So not even using like PowerPoints, but recording like videos. So if you're even just recording like a Zoom conversation where you're like talking to someone would be better than a PowerPoint that somebody's watching and trying to teach themselves. That would be even better if that's an option. Anything else?
It seems to me there's a role for leadership, educational leadership, in some of these ideas like that you've talked about, like not putting the burden on the presenter to have to cover everything, like someone helping guide each, because I imagine educational leadership has to coordinate many different presenters on many different topics. Annie, have you seen successes in your own organization for how you work with your other educators to just coordinate these things so you don't get overburdened by how much you have to teach in any given moment?
No. Like I said, so I oversee I don't really oversee our didactics at our organization, but I'm probably the person who's in the best position to like reorganize our didactics. And it's still 45 minutes, blocks of time. I mean, I probably could make like a unilateral decision that we're only going to schedule 15-minute lectures, but I haven't. And I imagine if I did, it would be challenging because there is such a culture around, I need an hour, I need this much time because all of this information is important and I need to be able to disseminate it. And I can't give a 15-minute lecture. Like that's not enough time. And I imagine it would just be a really challenging culture shift for the folks who are coming to give lectures. And I can even imagine it might feel somewhat disrespectful asking someone to take it would not be disrespectful. I would not be meaning any disrespect at all, but I can imagine it would feel disrespectful to ask someone to take time out of their schedule to perhaps even travel to our organization to give a 15-minute lecture, right? That's a difficult ask. Um, so again, like as I was talking with Dr. Cole, like how do we honor and balance what we know to be optimal learning strategies with like the very real limitations and parameters of the systems and the culture that we work within? I don't know. I haven't figured that out yet.
Well, we'll make that a call to action of everyone in the room. Maybe someone will crack the code.
Yeah.
That's wonderful. Are there any other last questions? All right. Well, if not, I thank everyone for joining and give me a moment. Let me tell you a little bit about next month. It's an interesting one. It is different than all the others that I think we've ever offered. It is the name of the presentation is Multimodal Training and Mentorship for Forensic Evaluations in Asylum Medicine. It's being presented by Dr. Mary White. She's a physician evaluator from the Human Rights Clinic of the Icahn School of Medicine at Mount Sinai, and she works with Tufts here up with the main track in their human rights group. And oh yeah, Annie, can you put the CME show your screen for that CME slide one last time? And if not, I can also send it out to this group.
Oh my gosh. You know how I feel about sharing my
Screen
screen.
shares, I know. It can
Hold
be
on
catchy.
1 second. Let me try to get back to it.
But we'll
One
stay in
second.
here. So for those that would like to have it, hang around, you'll get that code in just a little bit. And if Annie doesn't find it, I will find it. To everybody else, thank you so much. Our next presentation will be April 11th, so 1 month from now. And we'll see you then. Thank you, everybody.